few minutes we'll be going through, I think you all received the journal articles, there were 2 of them, looking at the standards for reporting implementation studies. So the STARI checklist and the STARI statement. I've been ably introduced, so I won't go through that. So as implementation scientists, we know that implementation science is really tasked with developing the evidence base for how we can translate the research findings into everyday practice or routine care. And one of the major priorities for implementation science is the fact that we all see how much the health system struggles to deliver the benefits from all the good work that has been done, research, to deliver it into benefits for participants and the populations. So the translation from bedside or from bench to bedside to community has been ineffective and insufficient, and therefore very costly to governments, to health systems. So implementation science is therefore important in trying to address that gap. However, the studies have been traditionally difficult to find, and if you find them, they've been poorly reported, and therefore if they're poorly reported, it's hard to synthesize the evidence from those studies. So, specifically, it has been noted that one of the major challenges when reporting implementation science studies is that there's a poor, or actually lack of a good description of what conceptual framework has been used. What conceptual framework underpins the work that you are reporting. In what context are you carrying out this work? People or authors usually give inadequate descriptions of their context, and yet we keep saying as implementation scientists, context is everything. And so when you report and you poorly describe your context, how does someone then translate it to their own without even understanding? In order for them to tweak it such that it works in their context, they need to understand what your context, the context within which you perform this study is, and therefore it's one of the main points, a good description of your context. Then, how did you promote your intervention? How did you implement it? That has got to be properly recorded so that anyone who is reading about it will know what was done, and if need be and they need to adapt, they can easily adapt to their settings. And also answer questions like, did you observe fidelity, or to what degree did you observe the fidelity in your study? So, for the STARI guidelines, they were actually set within the context of healthcare and population health, which most of us in this room would deal with. However, we know that implementation science is not limited to that. It's wide. It's used in a number of settings away from just population health, whether it is education settings, it has been used in many different fields, economics and things like that. Therefore, although we are looking at the STARI guidelines within the health and population setting, just keep at the back of your mind that IMS is so wide. It is involved in the dissemination science, in the implementation science, in evaluation sciences, and then scaling up of behavioral, clinical, community, global health, and other interventions. Therefore, it has a relationship with other fields. And although the dark blue box of implementation is where they mainly concentrated, the guidelines that were developed come all the way from your formative phase, where you have pre-intervention, you're looking at what you're going to do, maybe you're piloting a few things, you're making some explanatory studies, you've done effectiveness and pragmatic studies, and then now you want to scale up, and those are the implementation studies, type studies you want to do. The guidelines are mainly focusing on that, but that is not all. So, the STARI guidelines. What were the objectives of coming up with the STARI guidelines? So, they wanted to develop standards for transparent and accurate reporting of implementation studies. So, if you remember a while back, the CONSORT guidelines that were developed for standards to report randomized controlled trials, right? So they develop a checklist, and studies have been done that actually showed that when we came up with these, there was subsequent improvement in the reporting standards. So this is where implementation scientists were looking to go. And they found a gap. In implementation science, we are always looking for a gap. What is missing? Why is this not working? Some of the many frameworks that had been used before, especially the one from the Medical Research Council that was looking at how to report complex interventions in the world, there was a gap in terms of how to translate what has been done into routine practice. So, what methods were used to develop these STARI guidelines? There was previously some methodology that was in the literature about developing health research reporting guidelines, and so the authors used that framework. They performed a systematic literature review of literature available reporting on implementation studies. They then compiled a list of experts in the implementation field. And these were multidisciplinary experts in clinical research, experts in public health, in global health, in economics, experts from patients at one point were also used. So it was multidisciplinary experts that they actually recruited. And then using what they call the Delphi methods, I'm not an expert at that, but I know it's like questionnaires that are set out and sent out to these experts. The first wave is sent out, they get their views, they compile a checklist, they come back, synthesize that information, get those views that really agree to a very high degree, and include them in a second list and send that out again, and then see what they come up with. So that's the method they used to generate the final checklist. So of 47 items that were got from the literature and that they thought from their experience were very important when you're writing a study, the first round they sent it out, the experts agreed on about 35 of them, so 80% agreement and above. 80% of them agreed on 35 of them. And then they sent it out a next round, and then there were 19 that 100% of the experts agreed upon. And that is then what they went forward with. And this really is the schema of what happened. So they approached 66 experts in the field from a diverse background, this multi-disciplinary team. And here, anyway, we will discuss this a little later. But 23 experts then wrote back from and chose items. So 66, 23 responded. Then 20 scored the first round. Then they recompiled the list, sent it out, and this time 19 sent back. And 19 of them were in agreement about 19 items they thought should be included in the STARI checklist. So after that process, they then went to a third process where they then called for one face-to-face meeting of the experts, and 15 experts actually turned up. This meeting was in 2015. They had 11 experts from Europe and the UK and 4 from US and Canada. And I kept wondering, okay, where is everyone else? Yeah. Well, it's multidisciplinary, I think it's international, it's representative, I don't know. Yeah. So they met in London. Yes, and you can see from the multiple disciplines. There were healthcare researchers, 9, journal editors, 6, healthcare professionals, 8. There was a manager there, I keep thinking healthcare manager, people methodologists, they didn't say who, and then guideline developers, I didn't even know they existed, and then funding bodies. So, you know, quite diverse, and as you can tell, several participants, you might be a researcher, health professional, stroke, guideline developer. So some people crossed, yeah, not just from, not exclusive. So that is how they then sat down to develop this checklist. And what they used actually was continuing the methods. The exercise, the Delphi exercise we talked about earlier, where they sent the questionnaires, these discussions followed on that. So they got the 19 items, and then other items came up during the face-to-face meeting. And these were from, you know, the context of other things that had been, or other papers that had been published, especially other standards, and expertise from the people in the room. So they discussed, they did not use consensus, they actually came to agreement on what should be included after discussion. And therefore, after the 2 days meeting, they went away and continued this discussion iteratively by email. So they then got feedback, and they had this penultimate draft, let's call it draft 0 of this statement, and then they sent it out to other people. They sent it out to patients, they sent it out to healthcare researchers, clinicians, you know, and other people working in the field of implementation science. So in the true sense of implementation science and the principles that they teach, this, you can say, was an involved way of doing things. Almost like, you know, a user-centered design. What do you think, what are your experiences, what should we include? And then they came up with the statement. They also presented these concepts and sought feedback during workshops, conference discussions, steering groups, and so you can see they tried to be as thorough as possible in coming up with this list. So, what are the concepts of this STARI checklist, stroke STARI statement? There are 2 important concepts that underlie this checklist. And the first one, on its own, already has 2 components. It's dual strand. It's a dual strand, as they keep referring to it. I kept thinking of the double helix DNA. So, 1 is your implementation strategy together with your intervention, right? So your implementation strategy is defined as those things that support your implementation. What are you going to do to support the implementation of your intervention? You know, my intervention is offering additional telephone access to asthma patients who have difficulty in accessing health workers. That is your intervention. In order to do that, you might need to train people on how to use the telephone and what they need to get out of the patients during that telephone conversation, right? So that becomes your implementation strategy, right? Your intervention is to offer telephone services for asthma patients to improve access to care. Yes, what are those other things you're going to do in order for that to happen? That becomes your implementation strategy. So, one of the strands is you must describe your implementation strategy and your intervention. The second one is you then have to describe what the impact of the intervention is on the population. And this is described in 2 ways, really. Many times we measure the outcome. I did this and this happened and I can link that too, right? So you're describing what the impact of what you did was. Sometimes the impact is very obvious. It's in the literature. For example, you cannot start looking for, I hope that's not me, you cannot start looking for the, it would be unwise to start looking for benefits of cigarette cessation, stop smoking, right? It's been done and it's there. Everyone agrees it's a good thing to stop smoking. Now, if you can just show that you reduce the prevalence of smoking, then all the other benefits are already there. So what is the impact of your intervention? So on one hand, you describe the implementation strategy and the intervention very well, then you describe your impact. Those are the two underlying concepts that are very key in the guidelines, and you must describe those sufficiently well. So after that dual strand, the second is to remember IMS and how broad it is. It is multidisciplinary, and it involves many methodologies that you have heard of from different areas. We use cluster randomized trials, we use controlled clinical trials, we use interrupted time series, we use before and after studies and all that. We use qualitative studies, mixed methods, all these things we discuss and talk about, we are going to embed in our studies. Therefore, as you use each one of them, you should remember that even those ones have their standards. And so as you use the implementation standards, you must adhere to standards from whichever other methodologies you're using. If it is a mixed method study, there are standards on how you report, how you do it. If it's a qualitative study, there are methods that they guide you. And hopefully in your teams, you have people who are experts in these different things. Someone who is an expert at the clinical trials, someone who is an expert in the qualitative research and can, for example, tell you how do we address things like reflexivity. How do I place myself within the qualitative study? What am I bringing to the table? What should I be aware of before I interact with people? So each of the studies on their own have their standards. And so that should always be at the back of your mind. The STARI checklist then has 27 items. And so we'll go through one by one. And now this is where it becomes interesting because putting them on a slide was not very easy. It's here, whether I want it or not, I have to. Can you see that? Too small? But you have the table. Yes. I had that printed out because that one is key, but it's also, it was hard to extract it here. So, they have 27 items that they want you to report on. And the first 10 actually point to your implementation strategy and your intervention. Just showing you how important those two aspects are. The one that has been handed out to you is not just, it's like a worksheet, right? Because then it has those arrows where you use this as a checklist when you're writing up, just to make sure that each of those points has been taken into consideration and is included in your paper. So, as we go through this, you will notice the double strand is the implementation strategy and the intervention. In some places where it cannot be divided into implementation strategy and intervention, it will just be like that. In places where you have to think about the two, then you'll see the two columns. And that's how it is. And in the handout that you have, the checklist is very good at explaining so many things that make it clear what you should include under that column or under that section. And if you go to their website, they've included lots of definitions. What do we mean by adaptation? How did you adapt it? What do you mean when you say I adapted this to fit this? What do you mean by context? What do you mean by fidelity? So many of the terms that are used very frequently in implementation science are defined and included. So, as usual, you have to have a title, which properly, and I think at the get-go defines exactly what the study was about, and in some way should identify it as an implementation study. So getting your title right is one of the things that they talk about that properly and clearly defines what you did.
But that doesn't mean that you need to necessarily use the word implementation science.
No. In terms of the second thing, it's an abstract, but this is the usual way we have written abstracts before. Yeah? The only thing is it has to be very clear what the evidence-based intervention you implemented was, and then you define the key implementation and health outcomes. Under that, you then go ahead and describe the problem, the challenge or deficiency in healthcare, and what you aimed to address. The fourth on that list is the introduction. Now, introduction is divided into the two strands. Introduce the implementation strategy, including the theory, the framework, the model. Whatever you used should be defined properly. And then you go ahead and give the scientific background or rationale for the intervention that you chose. How effective is it? How effective did you expect it to be? What is the evidence for that? So here is where you use the two columns, the implementation strategy and then the intervention. So after that, you come to your aims and objectives. You're looking at what are the aims, and then you differentiate between what were the aims of your implementation strategy that you chose, right? I chose training because it has been shown that this and this and this and this happens. And that is different then from the objectives of your intervention. Yes? If you think very carefully about it. Yes, you choose a certain strategy because, and there must be evidence for choice of that strategy. And your intervention, you chose your intervention because.
The intervention is the evidence that has already been proven to work. And you want to scale it up or you want to try it out in your own setting.
Yes.
So is the goal to see if that evidence can be translated as opposed to testing the strategy you use to implement that evidence?
So let's go back to that intervention. Your intervention might be something you want to roll out, something you want to do in order to decrease this evidence practice gap.
Let's take an example of a guideline.
Yes.
There is something new in the guidelines and you want people to take it up or to use it. That's
So the evidence is in the guideline,
yes.
right? What is that you want to do in order for the people to use the guideline? That is your intervention.
So there is one I was looking at this morning, that's the guideline. For Dr. Bate for the questions and the discussion. We have guidelines that recommend the use of isoniazid. And every time I see communication on it, it's very funny. But we know that at least in adults who are HIV positive and they don't have TB, use of isoniazid reduces morbidity, TB-related morbidity, adaptation mortality. So that is no, and it's in the guidelines. But if you go out today and visit maybe 5 or 6 clinics and see how many of those people are on isoniazid, you will share. And this is something that has been discussed 1,000 times. In fact, today I got a bit disappointed. People are saying, let's push isoniazid to the facilities. And I mean, it defies the stakeholder engagement. But so I think the idea there is what strategy? Because we know that isoniazid works. Clinical trials have proven that. And we have these patients who are living with HIV. And TB kills about 30 to 40% of the mortality. I mean, a quarter of the mortality is TB related. And that giving isoniazid reduces that TB by up to 50%. Okay? But now, the issue is how do you get the isoniazid to all of these people who actually need it? And that's where the strategy comes in.
So in just from what Irene discussed, you can have an implementation research that can test a strategy. So there are some hybrids we are talking about in the writer, the hybrid 1 or 2. So depending on what you're doing, if you're testing a strategy, like the issue we have discussed, so how do we get there? You want to test which strategy best works. That's an implementation research. One type of implementation research, some hybrid strategy. And then there could be another one who knows this thing, okay, it works, it really works well. And we know this approach is also one that they've used to deliver, but it has not reached the peak. How can we improve?
How can we scale it up?
The kind of things that's been explained about the asthma and telephones.
So, yes, implementation science is not only scaling up, sometimes it's testing things that haven't been tested before, how you deliver certain things, and then that becomes your intervention. That is what you're intervening with, okay?
Yeah, but back there, you already adduced evidence from the background of showing that this implementation strategy I'm choosing is already evidence that it works.
Pardon, I haven't got that.
The rationale.
The intervention.
The strategy could be working, but it has, for example, if something worked in the US, is it automatic that it's going to work in Uganda?
Yeah, don't confuse your intervention, yes, the one you're calling your intervention, and your evidence practice, your evidence that you want to put into practice. Right? There's evidence, isoniazid is good. Our intervention is aimed to get that isoniazid rolled out. Can it work? How do we get it working? Then we usually go through the whole process of identifying how come it's not working in our setting. We do our formative studies. We find the loopholes, and that is the evidence practice gap. Then we design an intervention to fill that gap. Right? Now, you must have reasons for why you are choosing this intervention, or at least why you hypothesize it's going to work. Right? And for the strategy you're going to use in order to cover the loopholes, you've also given us reasons for why you think that strategy will work.
So the evidence is not necessarily
No.
there is evidence on one side,
Yes.
there is the intervention on the other side, and there is an implementation strategy.
The implementation strategy is simply what you are doing to make sure your intervention works. Yes, that is your strategy. I'm going to train them in order to make sure that they deliver this intervention the way they should. Your strategy is training. Your intervention is something else, using the phone to provide access. So those are, you have to have those two very clear. Yes, Stella?
So in that case, when you're reporting results, would you report, so for example, like when you train, you see like a knowledge gain or something like that?
Yes.
So you would report like how many you trained?
How many you trained? What did the training involve? Yeah? Yes, and if you measured any changes in knowledge, pre and post training, and you have that, that's even better to show that, but also you can quote evidence. Training has been seen to work where there is a knowledge gap problem. Training of health workers to use the telephone, to use this has been shown to work previously, and therefore we chose training. And then so many other things as you go through implementation science, why you choose certain strategies. You get to give us the evidence, right? Then after you have done your intervention, you say, okay, the intervention I have chosen is this. Why did you prefer to choose that intervention? It seemed it was cheaper, it was affordable to us, it was this, and so we chose it. It also provided patients with wider access without having to have more health workers. So you're giving reasons and evidence for the implementation strategy, but also for the intervention itself that you chose.
What's the word count?
And guess what? That becomes the stickiest part of writing an implementation paper. I mean, quickly you just start wondering, okay, where am I putting all this stuff? But then we shall get to that. Is that clear? Yes? Okay. It will come. But yeah, so where were we? So again, sorry. But anyway, I don't know how many of these we can go through in detail. But again, when it comes to methods, you don't just describe, you describe and report on so many things that have been listed here. What is the location of your study site? What are the personnel like? What is the resources that you're going to use? What was the eligibility criteria? And under the intervention, you describe the population you're targeting for that intervention. So on many of them, you have then the two strands rather. Then you describe your implementation strategy and why. Then you describe your intervention and why you chose it. So under methods still, after you've described your methods, you then go to now what the specifics are in terms of how they can evaluate the methods that you use. The primary outcomes, the implementation strategy, how many were assessed, and then were there any predetermined targets? You put those there as well. And remember, you're doing it for both your implementation strategy and your intervention. Process evaluation, this is where again, it's almost crazy. I remember some of the work we were trying to write out, and very quickly it becomes too much. I mean, we did this, we did that, we changed, why did we change, how did we record those changes, all that. And most of it, as you'll see, goes into supplementary materials. But bottom line is you have got to write it. You've got to describe it. If someone wants to find it, they should be able to find it under supplementary materials, but it should be there. And therefore, you should record it as you do your studies. All these things that seem like too much detail, I changed this, I changed that, they affect the fidelity of what you're doing. You said you're going to do this, but at some point you had to change. Why? What were the repercussions? All that is supposed to be recorded. So, other things, methods of analysis with reasons. If you're doing a priority subgroup analysis, you should, define and put all that in the paper. You sometimes have supplementary of the method, supplementary of WhatsApp, so many supplements, but they should be available. Then again, for your results, you still remember you have your implementation strategy and you have your intervention. And therefore, the characteristics the implementation strategy and of the intervention itself should then be reported. For many studies, and you realize some studies don't cover this entire scope. Your study might not be doing, an economic evaluation of what happened. So many of these will be not applicable to your study. But where it is, then they should be there. And as you go through the checklist, if you didn't do this, it's okay. No, not applicable is what you should fill in. It was not applicable to my study. Because some studies are testing, scaling up, others are designing pilots to test feasibility, others, and all those are implementation studies. But many of them will have part of this checklist, others will not be applicable, and it's okay to then put not applicable. However, you should have thought about it. Yes, Fred?
Yes, you've said it at the end that even as you start designing your study, you should have a reason to leave out that component,
yes,
and therefore be able to explain it. Because then it becomes absurd for you to reach the writing time and then realize that maybe this aspect should have been important.
yes.
But if you clearly think about it and you think that it's not relevant to what you want to do, then it's okay. But you thought about it,
Yes.
and you weighed it and you realize that it's not necessary for what you're trying to work on.
Yeah, that's true. So as you write down all those things, even as you write your protocols for studies to carry out, all these, it might help you to already look at your publishing checklist. You work the other way around. Go through the checklist and see which components are going to be included in this protocol, which will not, and why. Therefore, when you're reporting, you already have thought about them, and you have your reasons, and it becomes easier. So I find that this checklist actually might be helpful for people who are even just developing proposals or projects, so that you think about all these things. And then finally, for the discussion, you're going to summarize your strengths and limitations, like other papers, compare with other studies, your conclusions and implications. And then, of course, your strategy, the implementation strategy you use, you should be able to discuss it in terms of policy, practice, and affordability, scalability of the strategy you chose. And the same thing for the intervention. By the way, you can have an intervention and you might have options of strategies to use to achieve it. And you choose one strategy over the other. And then you should have thought about it. Why did I choose that strategy over the other? And this is where it's helpful to think about it right from the beginning. Yeah, you might actually start out with one strategy and change, or start out with one and add another. Because when you go to the ground to start putting your intervention out there, you see and realize other gaps. So all that should be recorded. Yeah, so that was the checklist. In summary, really, it is like a logical pathway. People who are used to evaluation will go straight to thinking about their logic models. Yeah, it gets you thinking about all the steps and thinking about the logic of designing a certain intervention and using a certain strategy to achieve it. Why have I chosen this? And so that is one component of this pathway. A second one that's important, and we've talked about this, is a balance between fidelity, sticking to what you said you would do and doing it that way, and then adapting the implementation strategy to the intervention and the context. You'll always find you might need to tweak one or two things before you actually get it done. But have you recorded what you did, where you changed and why you decided to change? So we see how far away from what you said you would do you have actually gone. Yeah, you might say you're going to do this, then you tweak so many things, it becomes something else.
And you drift.
Completely, exactly, you just drift, and we find you on the other side doing something completely different.
And maybe to add to that, if you drift, it's also not ethical.
Because if you gave your project to the ethics committee and they approve your project and then you decide to do, that's another process. You have to go for the amendment to the ethics committee.
And then you can't quote in your study that is the strategy
That you use, yeah. Things have since changed.
because then you completely moved away from it.
And then, as usual, a rich description of the context. This one you have to. Because we are telling people to scale up things, we keep saying low-income countries, context. No, there are certain things even with low income, middle income that will differ. If you have not defined your context specifically and in a very in-depth way, right down to resources, the people, how things are done, you will miss something. Okay? So always keep it in mind because it might enable someone to scale up in their own population, but keeping in mind the fact that yours had a few differences. So it's the more in-depth you get, the better it is. Okay. They then told us that this is an evolving document. So many things will come up, they expect, but they hope that it added clarity to how to design and report on what you did in implementation science. But the two challenges that were reported on are what we already discussed, the use of diverse methodologies in implementation science. You know, the menu is wide. And then there's this challenge of the requirements to record everything. Where do you publish? I mean, who are these people who are going to allow 3,000, 6,000? Some journals do actually. These deep social science journals, they might, but still with implementation science, you have got to be quite innovative in reporting. So tables and schemas and diagrams on how you did things, right? In addition to the supplementary materials that can be, you know, loaded online as supplements is a way to go in order to, you know, beat the word count limitation, okay? Because there you are reporting on cost effectiveness, you're reporting on implementation strategy, you're defining the context, you have a lot of material. Another thing to think about is in how many phases do you want to report this? You don't have to report it in one paper. How can you cut this out into chunks that can be, you can tell your story in a coherent way, but not at a go. Yeah. All right.
Okay, thank you very much.